Great. Well, thanks, Remu, for that kind introduction, and thanks, Matt, for warming up the audience for me. Uh, Always a great privilege to talk about topics that I think are really important to the ways that we perform clinical trials. And really what I'll take you through today is a way to make the DRIVE initiative practical for implementation of clinical trials. And Remu gave me the provocative talk of do not cut and paste. In the spirit of that, I actually was back at the break changing my slides to be able to update to DRIVE 2.0 so that I did not cut and paste the old DRIVE 1.0 into this version. So these are my disclosures. They relate to my consultant work related to the development of clinical trials for lymphomas, as well as research funding related to my role as division head for cancer medicine, where I oversee all the clinical alliances across MD Anderson. I'll go through the first few slides relatively quickly because I think these are topics that have been covered well and are well familiar to the entire audience in terms of where the challenges exist around enrollment of some of the pivotal clinical trials. And I think importantly what these data show are that when we go to translate clinical trials from the completion of the pivotal clinical trial to patients who are out in clinical practice, that when the pivotal clinical trials do not represent the patients that we're seeing in US-based practices, it's hard to know how well those trials translate in terms of the expected efficacy and the expected toxicity. And these just show, as an example, the participation rates for Black participants enrolled in clinical trials supporting the CAR T-cell approvals. And this is shown here as well from a publication that came in JAMA Network Open in 2022, looking at the first publications of those clinical trials where there was either limited participation or that there was no reporting of those results. As you've heard about earlier in the talks today, the DRIVE initiative really provides a roadmap for how we can understand the best ways to implement high quality practices in clinical trials. So the first comes in place is the DRIVE officer. And again, this is an update to DRIVE 2.0. And you can see there, as you heard about at the beginning of the talks this morning, the responsibilities of a DRIVE officer. And I'll introduce you to one DRIVE officer that we have at MD Anderson, who's done a lot of work really focused on this work, Chijoki Enze, who you'll see a picture of later on in our work, where he's been really addressing many of these points to be able to prospectively develop achievable and effective plans for enhancing our clinical trial enrollment, establishing an infrastructure to be able to do that, identifying particular impediments to meeting accrual goals at both the micro and macro level, developing culturally appropriate study materials, as I'll talk a little bit about, to promote accrual, identifying scientific questions and research questions in study design that improve our methods around clinical trials accrual, and then advising study sponsors and our PIs about the challenges in addressing those solutions. And this is work that Chijoki published last year in Blood Advances, looking at clinical trial accrual at MD Anderson, where you can see across a series of variables the impact on clinical trial room participation rates by self-reported race, by a socio-demographic measure, area of deprivation index, and age. And you can see by self-reported race of participants in clinical trials at MD Anderson, there really were no differences. Again, this now are patients that were able to make it to MD Anderson to be able to receive their clinical trial or the opportunity to participate in a clinical trial. And so that is a factor that is not accounted for here. But among those patients who were able to come to MD Anderson, there was no difference by race. There also was no difference by socio-demographic status and area deprivation index. The major difference that we saw were differences in age, and there were some differences in terms of the diagnosis, where approximately 20% of patients who come to MD Anderson in our lymphoma group go on to a clinical trial, where by diagnosis, about 60% of our patients who come with mantle cell lymphoma go on a clinical trial. And I think that is owing to clinical trial mechanisms for rare diseases that are present there. You can also see Jajoki has gone on from that work to be able to look at patients across MD Anderson at our main hospital on Holcomb, as well as our county hospital and Harris Health, to be able to look at the barriers and facilitators for trial participation. You'll see more data on this at this year's ASH meeting. This just shows the demographics of patients that he's already studied to be able to try and identify what are those barriers and facilitators, and that will get presented later this year. Leveraging that, he's not only taken this quantitative data approach, but also a qualitative data approach to be able to understand what are the factors that influence patients' participation, and then redesigning the clinical trials, both in terms of the eligibility criteria as well as sociodemographic factors around trial enrollment that helps to provide both an integrative interpretation of our data, but also implementation strategies to be able to address those barriers and to promote the facilitators that patients have described. The next I'll turn to is the rank score for clinical trials, and you've seen this earlier today as well, and also seen components of this as well in terms of the FDA's Omnibus Reform Act and call to action. And we've leveraged that in terms of individualized strategies for patients. And there you see Jajoki along with another one of my mentees, Alex Herrera, who's at City of Hope now, where they just recently published these new strategies for enhancing enrollment of underrepresented minorities in clinical trials at the tail end of last year. And I would encourage all of you who are interested in this topic, particularly with a focus on lymphomas, to turn to that report. They went through in a very comprehensive manner each of the factors that can be addressed in clinical trial design and in the design of eligibility criteria. And the ways that we can implement that individualized strategy relate to something that you've also heard in DRIVE. And I will pause for some time to just talk through this slide with you. So this is a slide that describes the data that we generated from our lymphoma epidemiology of outcomes research study, where across 8 academic medical centers, we've enrolled now more than 7,700 patients in our first 5 years with lymphoma on this observational clinical trial. This really gets back to the point that Karen Wingfield made earlier, is that observational studies can be a nice entryway for patients getting into the clinical research and clinical research arena, and then to be able to leverage that to go on to therapeutic trials. And I could say one of the things that I'm most proud of this patient population is that if you look at the demographics of our enrollment across these 7,700 patients, that they really look like the demographics of lymphoma within the United States, with some minor exceptions. When you look at the age demographics, we really look by and large like patients in the United States, with the exception that in the oldest old population, those patients over the age of 80 were not quite as well represented. But when you look across men and women, those look to be quite equivalent. We're within 5% of enrollment of Hispanic patients with lymphoma as there's represented in the United States, and have a similar representation of Black African American self-reported race as is seen in the United States. And I think the other thing that this represents in the map is what you heard about from Matt just a little bit ago, is the geographic distribution of patients. While our 8 sites are all to the right of the Mississippi, and you can see that the preponderance of our enrollment of patients also matches that. We touch all 50 states in terms of our enrollment, and we touch the geographic diversity addressing rural patients in the United States with lymphoma. Those patients who are listed in the brightest yellow are patients who come from urban areas, but all the remainder of those are patients that we would consider rural, who also have worse outcomes. The other thing that we've been able to do with this data set is to be able to leverage that, to be able to understand how do the kinds of clinical trials that we create impact enrollment. This used the LEO data set, and particularly the 2,700 patients with diffuse large B-cell lymphoma that we enrolled in that data set, to be able to understand with frontline immunochemotherapy trials, how did the laboratory-based values impact enrollment on clinical trials. And that was presented by Arushi Khurana and is now published as well. And what you can see here is that if you look across the frontline trials for diffuse large B-cell lymphoma that have occurred over the last decade, that the eligibility criteria that were designed, and this is just looking at 5 laboratory-based eligibility criteria, not all eligibility criteria, that they actually disproportionately affected individuals that you would most like to have enrolled on those clinical trials to represent the demographics of the United States. And so we've gone on from that to be able to look at and leveraging our LEO group of experts, where we have experts across 8 academic medical centers who have been involved in the design of clinical trials, including the leader of lymphoma in the ECOG, the SWOG, and the Alliance Group, as well as about 10 members on the National Clinical Trial Network Steering Committee for Lymphoma, which I also sit on, as well as the 2 chairs of the steering committee. And leveraging those experts, we went through the eligibility criteria for diffuse large B-cell lymphoma clinical trials to try and identify which were those clinical trial criteria that were necessary, which ones were unnecessary, which ones among those experts was there some agreement on, and which ones were essential. And we used a modified Delphi approach to go through these eligibility criteria. And if you look, on average, there were about 39 eligibility criteria for diffuse large B-cell lymphoma clinical trials. And through this process, we narrowed that down to about 13 criteria that we viewed as being essential for enrollment on clinical trials. We've now leveraged that with companies to be able to design new first-line trials that have simplified the eligibility criteria to be able to make those the kinds of eligibility criteria that are more likely to enroll patients. And I think as we move forward, we'll leverage things like what you heard from Andrew this morning about leveraging Duffy Null as another one of those factors that helps us to improve our eligibility for patients enrolling on frontline trials. And the last thing I'll turn to is the E, or the elevator, and enhancing the training of research teams. That's been something that has been very important to me in my career in terms of engagement, both first with what used to be called the ASH Minority Recruitment Initiative, now is called the ASH Healthcare Inclusion Pathway, where we have a continuous unbroken pathway from the first year of medical school all the way through the 4th year on faculty. So really 13 years of funding to be able to help individuals. We just recently published the results from this work and showed that we've provided awards to more than 400 individuals across this spectrum, across the 6 different programs. And when you look at the retention of individuals who started in the medical student program, 13% of those went on to careers in hematology, which is different than medical students as a whole, which is about 2% of individuals would go on to careers in hematology if you just take all comers in terms of medical schools. The other thing, the other program that I've been involved with more recently is this work with the Robert A. Wynn, what's now called the Wynn Excellent in Clinical Trials Award Program, which is a 2-year program that is focused specifically on this issue of enhancing the diversity of clinical trials for patients. And it's been an outstanding program, and you can see across now we've finished our 4th cohort of trainees across, and I met with cohort 3 just this week to talk about their updates on clinical trials. That you can see that we're now developing a broader cadre of experts who are able to go out and to be able to influence clinical trials in the future. We've also been able to do this with a series of grants to be able to enhance the group across LEO. I mentioned to you the LEO grant at the outset, but we leveraged that to create diversity supplements to support others to come into the field, as well as additional grants. And you see the work from Jijoki Enze highlighted there at the bottom. That I will turn to in specific, where he's now leveraged our work through an additional grant from the Leukemia and Lymphoma Society that I lead to be able to expand clinical trials out into community-based practices. And that includes both LBJ, our county hospital that I mentioned to you as the Harris Health Hospital, UT San Antonio, which serves approximately an 80% Hispanic population in San Antonio, the UT Rio Grande Valley, and other smaller community-based practices. There, we're implementing all those kinds of things that I described at the very outset of DRIVE in terms of having patient-specific implementation strategies to be able to enhance clinical trials in those areas. And we're partnering with other leaders within the impact networks that also have LLS funding grants that have been connected to Leo, Greg Nowakowski at Mayo Clinic, as well as Jonathan Cohen at Emory and John Leonard at Weill Cornell, which will ultimately create a network for being able to enhance clinical trials broadly and implement these strategies that you've heard about in DRIVE. And with that, I'll stop, and I think we'll take questions in the panel, right?